Welcome to the presentation on boundaries in psychotherapy, social work, counseling, and marriage and family therapy. I'm Ofer, PhD, a licensed psychologist, ethicist, instructor, expert witness in forensic cases, author, and most importantly, anthropologically critical thinker. In addition to the dozens of published articles that I have published in my life, APA Book has also published a book on the same topic we're going to talk today, boundaries in psychotherapy. So welcome. Let's kind of start with what does it mean, what's included in boundaries in psychotherapy. What's included is gifts between therapists and clients, self-disclosure by therapist, physical touch by either client or therapist, a bartering arrangement, dual relationship between client and therapist, like, for example, attending the same church, local concerts in the community, hiking groups together, kids going to the same school, etc. Also, what belong in boundaries is home visit, online therapy with our phone or Zoom, which is so popular these days, interacting on social media, which is another new complexity that many of us facing, and session outside the office, for example, when you do a home visit to a client. I used to do walk and talk therapy, systematic desensitization of phobia, so outside the office. So sometimes we attend a client's wedding or funeral and school play. All these are boundaries. There are two types of boundaries, and boundary crossings and boundary violations. Any deviation from traditional strict only in the office emotional distance form of therapy is considered boundary. It's very odd term. Basically, they all make this to be departure from traditional psychoanalytic or rigid risk management approaches. So boundaries, it's kind of a very vague term because it's included in traditional psychotherapy. Boundary crossings are ethical within the standard of care and are clinically most of the time supposed to be helpful. A boundary violation, in contrast, are obviously different from boundary crossing. And this is when therapists are acting in a substandard care, illegal, unethical, and or harmful to the patient. So again, very important to differentiate boundary crossing from boundary violation. Harmful boundary violation occur when therapists are engaged in exploitative dual relationships, such as sexual contact with current clients or exploitative business relationship. This would be harmful boundary violation. Boundary crossing, in contrast, can be an integral part of well-formulated treatment plan or evidence-based treatment plan. So we need to really, some people just talk about boundaries as if there's only one type of boundaries in therapy. There are two, boundary crossing and boundary violation. So giving supportive hug to a grieving client or accepting small termination gift from a client, flying in an airplane with a patient who suffers from fear of flying, bartering with a cash poor farmer in a community where bartering is normal, lending a CD to a client, making a home visit to a bedridden patient, attending a wedding of a couple that you have worked for few years with, going to see a shy client performing in a show, or accompanying a patient to a dreaded but important doctor appointments. All these are examples of boundary crossing that are supportive and clinically appropriate with a client. Ethics code of all major psychotherapy professional association like APA, NASW, ACA, NBCC, CAMF do not prohibit boundary crossing. They do prohibit boundary violations. So again, this junction. As I noted in my YouTube on dual relationship, Almost all code of ethics states that multiple relationships should be avoided only if they could reasonably expected to impair the therapist's effectiveness or cause harm. So, kind of another quick note about dual relationship. Therapeutic orientations such as humanistic, behavioral, cognitive, family system, feminist, or group therapy often endorse all kind of boundary crossing as part of effective treatment. What constitute harmful boundary violation, as I mentioned earlier, is that within traditional psychoanalysis, you're supposed to be kind of not looking at each other, not revealing anything about yourself. So this is just within psychoanalysis. Boundary crossings, such as gift, touch, home visits, and are unavoidable in some community when expected such a behavior. It's rural community, military, university, and interdependent communities such as church, immigrant, ethnic, deaf, LGBT. So it depends what's the context of therapy. This will determine what kind of boundaries, boundary crossing are acceptable. Different cultures have different expectations, customs, values regarding therapeutic boundaries, such as bartering. You work in rural communities, and bartering is kind of acceptable, and it's normal part of the community. Self-disclosure within some communities are mandated to effective therapy. Some community will be much more open to physical touch or home visit. So it depends on where therapy takes place to what kind of boundary crossing are expected and accepted. And also kind of another confusion in the field that not all boundary crossing constitute dual relationship. People tend to confuse it too. Making a home visit, going for a walk with a client, or what I call walk and talk, attending a wedding with a client are boundary crossing, but not necessarily dual relationship, because you have only one role of a therapist, even when you do a home visit or you attend a wedding of a couple that you have worked for a long time with. And there is a very prevalent, erroneous, and unfounded beliefs in the field, what we call the slippery slope, that claims that minor boundary crossing inevitably lead to boundary violations. This is kind of really paranoid view of boundaries and interaction. This illogical, unscientific, and paranoid approach is based on the snowball effect. It wrongly asserts that if you give a simple gift, you may end up in business relationship. How dumb is that? Or the non-sexual hug inevitably turn to sexual relationship. Again, it's equally as dumb. So the rigid attitude towards boundary crossing stem in part from what we have been called sexualizing boundaries, the rigid Western European standard of keeping camps separate. You know, and here in the United States or in many other places, there are other communities, community of color, Spanish communities that have the different relationship between professionals and clients. Boundary crossing with certain clients, such as borderline personality disorder, must be handled with caution. So when we talk about boundary crossing, it really depends who is a client and who is a therapist, what's a culture, what orientation, etc. Boundary crossing, like multiple relationships, should be implemented according to the client unique needs, diagnosis, history, etc., and the context of therapy. That kind of I continue to emphasize that we need to understand our interaction with our client within context. It is recommended that the rationale for the boundary crossing be articulated in the record, and more complex one can be even included in a treatment plan. So the appropriate meaning and applicability of boundaries can only be understood, I'll say it again, within the context which therapy takes place. What's in the context again? It's so important, so I'll repeat it. Who is a client? What is a setting? Is a setting is military? Is a setting in small town? Is it downtown New York? Is it in Hollywood? Depends what it is. Then what kind of therapy are you doing? Psychoanalytic, which will create a different boundaries, or do you do humanistic, which would be much more flexible? And also on the therapist, what culture and what orientation the therapists bring into the room. Attitude towards therapeutic boundaries have been significantly changing since 1990s. So people understand that boundary crossing and boundary violation and boundary crossing can be very helpful and help with the therapeutic process. So there's still a long way to go, but there's better understanding of the nature of boundaries and the importance of flexibility. I must add that when APA published my boundaries book, American Psychological Association books, in 2007, it was a major step in differentiating ethical boundary crossing from unethical boundary violation. So giving APA credit, and NASW also publish similar books. And so it's important to realize the boundary crossing as well as boundary violation can be also initiated not only by the therapist, but also by the client. So client may initiate a hug. Client may initiate, which will be a normal hug, will be boundary crossing. If client initiates sexual touch, which happened to many therapists who have been working long enough, and this will be a boundary violation, but it's boundary violation initiated by the client. I got a gift of a car one time by a client, and this was definitely inappropriate. I didn't accept it. It was in my book, boundary violation by a client. I didn't say that. I just said, thank you so much, and I didn't take the car. This is by a multimillionaire. A client may initiate appropriate or inappropriate connection on social media, and late night call or text can be also a boundary violation. A bartering arrangement are very complex, and clients can also initiate some kind of irrational, inappropriate bartering arrangement. So it's important also to note that not all boundary crossings that I mentioned before also constitute dual relationship. We talk about we need to separate these two constructs. Making a home visit for clinical reason, it's not dual relationship. Accompanying a client to a dreaded but important medical appointment, it's not dual relationship. When I did walk and talk therapy with clients, it was not dual relationship. I was just a therapist and we're a client. Attending wedding, confirmation, bar mitzvah, school play with a client also do not constitute dual relationship. Friends on professional social networks such as LinkedIn may not be necessarily belong to this category. Having a meal with an eating disorder client for clinical reason does not make it dual relationship. Conducting session outside the office, as I mentioned before, with the claustrophobic clients or whatever other reason also does not involve dual relationship. A note about power relationship in therapy, which is a complex issue, and I'll have another YouTube video for that. Unlike the myth of inherent power differential or imbalanced power or client inherent vulnerability, a power relationship are not that simple and not always clear. While therapists have some type of power, it's also clients have different kind of power. And I think for the therapists who are listening to this presentation, when we therapists go to a therapist, we don't feel that they have all this power over us necessarily. So it's a note about power, which is related to boundaries and related to dual relationship. That kind of the power is a more complex issue that we therapists are always in a powerful position. In summary, boundary crossing are ethical, legal, clinically advised, and within the standard of care, and some of them are unavoidable. In contrast, boundary violations are unethical, illegal, below the standard of care. And the final note is boundary crossing do not necessarily lead to boundary violation. So I'm inviting you to check my website, drzuri.com, for lots of article, online courses, video, audios, books on the topic of dual relationship and the boundaries and many other type of boundaries. And you're also invited to make a comment on this YouTube webpage. Thank you so much.